So let's record. All right. So Nikhil, you are again in your clinic, and 65-year-old. This is a true patient. Okay. So hang on. Sorry. Let me just 1 second. Let me switch off this. So 65-year-old guy, a male, a doctor by profession, an ex-smoker, comes with cough, weight loss, with a past history of coronary artery disease and diabetes, oral hypoglycemic diabetes. Okay, don't tell me history and all that. Just go to investigations, because we don't have time. We need to discuss the mediastinum. So forget the history, forget the thing. Just on the basis of this, what is your first suspicion? Nikhil, start talking.
Cough with weight, with this if the significant weight loss. The first diagnosis will be the malignancy and infection.
Okay. So you want to rule out malignancy, okay? Because I've told you he's a smoker.
And infectious component.
Which are the 2 risk factors that I've placed here? For malignancy, what are the 2 risk factors or 3 risk factors?
So old age more than and smoker.
Yeah, so male is important. Okay, lung cancer is more common in males. Yeah, so don't forget the males. Forget the 65-year, but male and smoker. These are the 2 important risk factors. And then the symptom is weight loss. That is the key thing. So if there was hemoptysis as well, you would worry. Okay, but weight loss is a significant risk factor. Okay, so just think of lung cancer. What investigation you want to do?
So chest X-ray, AP and lateral.
Good. Okay, there you are. So that's an AP chest X-ray. That's all I have. So just read this quickly to me.
There is an irregular mass lesion in the right lung, right lower lobe.
No,
Actually,
on a chest X-ray, you cannot say
cannot find
lower, upper, or middle. So what do you call it? No,
what do you call it? Lower zone.
Lower zone. The word to use in a chest X-ray is zone. Very good. Well done.
Zone.
What else?
There is no, it's irregular. There is no pleural effusion or pleural thickening. Trachea is in central. Airway is maintained. There is no other lesion seen in the same or other side of the
so
lung.
when we talk about, now we'll get to specifics. Okay, Nikhil, don't go into too much detail. Just when we talk specifically, I give you a very short history. Okay, in an exam, that's what we do. When we give you a very short history and we are suggesting malignancy, then what are the 2 important points I want you to tell me on this chest X-ray?
Sir,
one is you told me that there is a mass in the right lower zone. You told me there is no pleural effusion. Both are very good points. What else I want you to tell me?
Sir, any other lesion in same side or opposite side?
Okay, before that, what else you want to tell me? Think T and M, nah. Think T and M. You told me T. You just told me no lesions elsewhere. So you're talking about M.
No highland.
You want to tell
no
me?
highland. No.
Sir, yeah, talk about the mediastinum. Talk about the mediastinum. Okay.
So there is no widening of subcarinal angle or obliteration of paratracheal stripes.
Okay, good. So that's what there is no fullness, no obvious fullness, at least not on this chest X-ray. And subcarinal, you may or may not see it. It's fine. The exposure is not great here. So actually you cannot see it. Next step, talk only specific now, okay? Because I want to get on to discussion. Next step, treatment, investigation, next step.
Sir, is there a lateral X-ray available?
No, I don't have it at the moment.
Sir, I like to go ahead with serum creatinine.
Okay, bloods and all are done. Next step in the investigation.
Sir, see, in this case, CCT chest.
Okay, CCT chest. Why do you want to do CCT chest?
Sir, I like to confirm my diagnosis that this is a mass lesion, and secondly, to rule out any signs of improbability.
Do you want to do any other investigation in the whole thing? CCT chest is adequate?
Sir, with abdomen.
Sir,
talk about
do a PET.
No, who is this? Who is this?
Sir, Bishwarup, sir. Sir, we would like.
Bishwarup, just wait. Let me ask one specific question. and then I'll come to you next. Okay. So just wait, because we're doing this online. So if too many people talk, we don't know. We won't get to it. So just let me ask specific questions to specific person. You're on the panel, don't worry. And Simran's on the panel as well. Okay. So what was my question? I forgot now. Where was I?
So which investigation I forgot to mention?
Yeah, you said CCT chest. So that I'm not happy with that. So next stop there. Biswarup, what other investigation you want to add to this?
Sir, we would like to add a PET scan to this.
Nahi re Baba. Before PET scan in CCT chest, are you happy with CCT chest? If you are filing a radiology form, if you're filling a radiology form, what are you going to fill? Simran, what are you going to fill?
So along with CCT chest, we like to scan the upper abdomen, liver, and adrenals as well.
Not upper abdomen, whole abdomen and
Whole
pelvis.
abdomen.
And pelvis. Don't forget pelvis. Okay. So you do a chest, abdomen, and pelvis. Now, Biswarup, why do you do chest, abdomen, and pelvis?
Sir, to see if there is any metastasis in the abdomen or in the pelvis.
Yeah, where? You have to talk specific, no? This is adult level discussion, man. Come on.
To see if there are any liver metastasis, and to see if there are any pelvic metastasis, or to see if there is any primary in the liver that we are missing,
No.
or in the abdomen.
What is the commonest thing you want to see with lung cancer in the abdomen?
Are there nodes?
Simran, come in.
So
what is the organ you want to see in lung cancer?
So we want to see the liver, we want to see the adrenals, and we want to see the celiac.
Adrenals, you're absolutely right. Adrenals. The commonest association is brain, lung, and adrenals. Okay. So in an exam, you're not saying wrong. Everything you said was right. Biswarup, everything you said was right. But I want you to zoom in and do an adult discussion with me. Okay. So liver was perfect. I agree with you. Abdominal nodes is all perfect. But what you really need to see is adrenals. That is important. Okay. All right. And pelvis, why do you want to see if it's a female patient? Biswarup, why do you want to see pelvis?
To see if there are any ovarian metastasis.
Or
if there is a primary in the
pelvis. Absolutely. So in a female, when I told you what you want to see is not ovarian metastasis is not common. It is ovarian primary that you want to see. Okay. That's why you do pelvis. Okay, good. So this guy's had a CT chest. I don't have the image of the CT chest, but it shows a lesion in the right lower zone, right lower lobe with some fullness in the mediastinum. Nikhil, come back in.
Yes,
what is the next step you want to do? Lesion in the right lower lobe with some fullness in the mediastinum and subcarinal space.
So I like to do a PET scan.
Okay. Do you want to do a CT guided biopsy before?
No, sir. I like to do a PET scan if there is on imaging there is a fullness in the mediastinum. Probably I like to rule out metastasis, and if possible, any other site of easier site of biopsy.
Okay. So if now Simran come in. Okay, stop, Nikhil. Simran come in. I'm going to show you a image of a PET scan with 3 arrows. I want you to point out what are the 3 arrows. Okay. Simran, get ready for it. Okay. Just name the 3 arrows.
So the first arrow is the mediastinal pool. The middle arrow is the lymph node on the contralateral side, contralateral hilum, and the arrow on the right hand side, lower one, is also a lymph node in the right mediastinum.
Oh, so you're coming from the top to the bottom. Okay.
Yes, sir.
Okay. Biswarup, come in.
Sir.
Identify the 3 arrows.
The first arrow, I mean, the one from the sternum side, sir. The first arrow is a mediastinal lymph node. The second one is looks like a periaortic lymph node, and the third one is also, I mean, on the right, so it is left. Yeah. So the second arrow is a contralateral lymph node, periaortic lymph node, and the third one is also a lymph node, but in the same side of the mediastinum.
Okay, Nikhil, come in. Identify the 3 arrows.
So it's the same what they have said. Hilar node, sir.
What is the first arrow? The one near the sternum.
See, it's a
This is the ventricle, sir.
Yeah, so it's not mediastinal pooling. You said mediastinal
Right.
pooling.
Right, sir.
Cardiac uptake?
Yeah, it's a cardiac uptake. So which of this is
Oh.
physiological and which is not physiological?
The brighter ones posteriorly are pathological.
And what about the one at the top, that arrow on the top? Is that physiological or is it
Physiological
pathological?
uptake.
Absolutely. I specifically put this up because you must be able to identify areas of physiological uptake in a PET scan. This is the myocardium, okay, that you're seeing. It is not mediastinal pooling. If I show you here, can you see my arrow? Can you see my arrow, guys?
Yes, sir. Yes, sir.
yes,
Yeah,
sir.
this is mediastinal pooling. This
Right,
is
sir, right.
myocardium. Yeah, this
Right,
is
sir,
mediastinal pooling.
Right,
And
sir.
so next question is to Nikhil again. Tell me sites of physiological uptake in a PET scan.
So the myocardium.
Okay, good. Tell physiological, just where the dye goes, where there is more activity, where is it excreted? It's simple question, man. Don't get stuck.
Bladder,
Bladder,
Before bladder, what comes?
kidneys,
renal,
Yeah, renal colysis.
Renal.
Renal colysis. What else? Where else can the dye get metabolized?
liver,
liver,
Liver. Sometimes in liver you get pooling, okay? And that could be, there is always a shade on the liver which shows that this is physiological uptake. Where else do you get physiological uptake?
adrenals,
Yeah, a little bit, not that common. Yeah. What else? More common things. Two more organs. Give me two more
Thyroid.
organs.
thyroid,
Huh?
thyroid.
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 Very good. Thyroid. Excellent. And one more organ.
Brain.
Brain. Absolutely right. Now, Biswarup, give me the same answer in a as if you're giving a viva. What are the sites of physiological uptake?
Sir, brain, thyroid, myocardium, kidney, bladder, liver.
Okay. All right. That's fine. Good. Okay. Does that make sense? Okay. Soumya, come back in and identify this arrow. Same patient.
ipsilateral hilar node,
What is the location of this lymph node? Where is it located? Anatomically, where do you think? Can you see the, what is this? What is this?
paravertebral,
Yeah, so this is paravertebral. Okay. So anybody else wants to tell me? Simran, come in. Where is this lymph node located?
Prevertebral.
Paravertebral. There is prevertebral, I agree with you. But this one which I'm pointing to is paravertebral. So where is this lymph node located? I want to see
So,
whether you're thinking or not.
So level 9.
9 is inferior pulmonary ligament. That will come a little bit lower because this
posterior to
is,
pulmonary veins,
So 8. Level
8 is what? What is 8?
Paraesophageal.
Thank you. So this potentially could be next to the esophagus. Yeah.
Right, sir.
It still could be mediastinal. We don't know that because I've not shown you
Yes,
the
sir.
sequence. But because
Yes,
it's in the right paravertebral gutter, the right paravertebral gutter extends from ear to ear. Okay, this whole thing. So the organ which runs through the right side on that area is the esophagus. So it's likely that this is near the esophagus. Do you understand that? What is the significance? Why did I show you this particular view for this lymph node? Soumya, you can come in and tell me, why did I show you this shot? Okay, Biswarup,
not
come in
sure.
and tell me. That's okay, don't worry, Soumya. Biswarup, come in and tell me, why did I show you this shot? What is the
Sir,
significance? I'm thinking
sir,
clinical. Why did I show you this shot?
Sir, as we come down from 10, it indicates that the mediastinum is getting involved. So this is station 8 probably. So the
Yeah, but
mediastinum
why
is
did
getting-
I show you station 8 lymph node? What am I thinking?
So continue.
Okay. Okay. I will ask you another question. Okay. I'll ask you the same question in another way. Simran, no, Nikhil, come in.
Yes,
Nikhil,
sir.
how will you biopsy this lymph node?
Sir, by EUS.
EUS, excellent, well done. Okay, so that is the significance that this is next to the esophagus. You cannot reach this lymph node by CT guided biopsy, it looks too deep. You cannot reach it by EBUS, but the one investigation which will get you to this lymph node is EUS. Do you understand? This is how we analyze. When we are looking at CT, we are also thinking of the next step, because the next step is biopsy. If I showed you the previous scan, this one, I'd ask you, how would you biopsy this one?
EBUS.
EBUS.
EBUS, absolutely right. How would you biopsy this one?
This is what.
Also EBUS, sir.
EBUS.
This one should
How
be
would you
EUS.
biopsy this one?
EUS.
EUS. That's how you have to learn to interpret CTs, okay? It's not just the CT or the PET that you're looking at. You're also looking at the next step of management. You understand that? Okay, good. Now, there is one arrow and one lesion here. Somebody read the CT. Nikhil, read the CT.
So there is a hypermetabolic activity in the right lung, as well as subcarinal lymph nodes.
Yeah, okay. Subcarinal and paraesophageal lymph nodes. I agree with you. That's good. Okay. How will you access that one with the arrow?
By EBUS.
EBUS. What are the other ways you can access it?
So EUS.
If you don't have EBUS, in your hospital, what is the other way you can access that?
Sir,
Extended middens.
EUS or
If
mediastinoscopy.
you don't have EBUS and you don't have
Extended
EUS,
Mediastinoscopy.
mediastinoscopy. But before mediastinoscopy, do you have anything else? Any other way to access that lymph node? Before EBUS came in, what were we doing?
So TBNA.
TBNA, transbronchial needle aspiration. Okay. This is how I'm testing your knowledge, whether you're thinking clinical or not. Okay. So subcarinal is the easiest one to do a TBNA, because you just have to go at the carina, put a needle through it. There is no vessel there. Okay. So in the old days, we used to do TBNA. Is that correct? Okay. Nowadays, you can do cryobiopsy as well. So, you know, you can do TBNA, you can do cryobiopsy. You don't need an EBUS for a subcarinal lymph node. You can just go in there and you can just put a needle through. Yes, go on.
So sorry for the question. So what is cryobiopsy?
Cryobiopsy is using cold, ice cold freezing. So you put in the needle and it's connected to a cryo thing and it freezes the thing. And when you pull it out, you get a nice biopsy along with it. Okay.
Right. Thank you.
That way you don't damage the tissue. So cryobiopsy is the new baby in town.
Sure.
Okay.
Thank you.
So cryobiopsy is also possible in this. Okay. How do you define this? What is this? How do you, if you want to measure it, how will you measure it? Oh, no, Nikhil, if you want to measure this, how do you measure it? You just said something. You're right. Tell me
SUV max.
confidently.
SUV max.
SUV max. What does SUV stand for?
Sir, maximal uptake.
SUV. There is an S, so don't say maximal uptake. What is the full form of SUV?
Sir,
Yeah, you said something. You know, you should know what you're talking about.
yes.
So standardized uptake.
Standard is maximal uptake.
No, U is what? Where is maximal in this? SUV. Give me one answer quickly. Biswarup just gave me. Give me the answer, Biswarup.
Standardized uptake value, sir.
Thank you. Standardized uptake value. Next question is to Simran. How do you decide SUV?
The SUV is decided according to the mediastinal pool.
Okay, good. That's fine. That's fine. Good. That's fine. I've understood. Do you want to finish the answer? Finish the answer. It's okay.
So if it's the same as the mediastinal pool, then it's the background is the same as the mediastinal pool, then it's normal. If it is more, then it's moderately uptaken. If it's bright like this, it is much more than much more SUV, sir.
Okay, good, fine. Somebody come in and tell me what is this. Biswaroop, tell me what is this.
This is the level of the trachea. This is the thyroid uptake, sir. This is the level of.
Okay, stop. Soumya, come in. What is this? What is the blue arrow? Sorry, say it loudly. I didn't hear you. Did you say thyroid?
I thought this was a pelvic cut with bladder uptake.
Thank you. It's the bladder. Well done. Why do you call it pelvis?
I thought you could see the hip
Excellent.
joint.
That is
and
the
there
answer. That is the answer because you can see the hip joint. Okay. So Biswaroop, don't get hooked onto the, we fool you like this in an exam. Okay. This is a straightforward bladder thing and you thought you're looking at the trachea and the thyroid. The shape is also not like thyroid. Yeah. So don't get hooked on. This is the trick question. Okay. And I fooled you completely. All right. So don't do that in the exam. Look around at everything. Don't just focus on that arrow and on the bright uptake. Look around. And the one thing that you look around is the hip there, the hip joint. Can you see this hip joint here? Yeah. So don't get fooled by the examiner. Okay. Now everything becomes clear. This is rectum, not thyroid. Okay. In fact, you can also see feces in the rectum. All right. Okay. Next. Nikhil, come in. What is this?
So it's a brain.
Yeah. Can you interpret this?
So it's a normal uptake, sir.
So the answer is you cannot interpret it. Okay. What you should tell me in the exam is, no, sir, I cannot interpret it. So my next question is, how will you look at the brain in this patient?
With the mediastinal pool, comparing it with them.
Hey, Baba, how will you investigate the brain?
Sir, MRI brain. I like to do a MRI
simple
brain.
MRI brain. Full stop. Okay. This is how you dig your grave and put your foot into it. Okay. I'm asking you a simple question. How will you investigate the brain? You should say you cannot interpret the brain on a PET. You need an MRI brain. Full stop. Okay. Don't dig your own grave. Okay. Now, next question is to Soumya. Soumya, tell me all investigative tools that will help you to decide, that will help you to state the mediastinum. Everything that you know. Simple question, nothing complicated. Yes. What are the tools available to you to stage the mediastinum in terms of biopsy?
First is the CT scan, which you have already done.
But go ahead. Beyond that, we are talking about biopsy. So we're talking about histology. So how will you obtain histology from the mediastinum? Give me all the tools available to you.
And
answer.
EUS, EBUS.
Good. So go one by one.
EBUS, EUS,
EBUS, EUS,
TBNA.
good. TBNA, good. Cryobiopsy, I just said. Okay. But before EBUS, like that, anything else you can do?
Chamberlain's.
Sorry?
Chamberlain's.
Yes. So surgical biopsy. Okay. Chamberlain's.
Surgical biopsy. VATS biopsy.
Wait. Surgical biopsy not finished. Wait. So you said EBUS, EUS, CBNA, cryobiopsy. Then you said surgical biopsy. Okay. Before that, one more tool.
Mediastinoscopy.
Before surgical biopsy. Mediastinoscopy is surgical biopsy. Any one more tool available to you for staging? Yeah, somebody just said CT guided biopsy. Okay, well done. So you always start with CT guided biopsy. Okay, so CT guided biopsy, EBUS, EUS, TBNA, cryobiopsy. Now, next question, Simran, what are the surgical modalities available to you for doing a mediastinal staging?
So surgical modalities, sir, are cervical mediastinoscopy.
Excellent.
Anterior mediastinoscopy.
Okay.
Chamberlain procedure.
Anterior mediastinoscopy or mediastinotomy?
So you can do scopy and either scopy or mediastinotomy.
Yeah, but Chamberlain's is classically mediastinotomy. So
Yes,
okay.
mediastinal. Yes.
Okay.
So then
What
you
else?
have video-assisted mediastinoscopy.
Well done.
Then you have VAMLA and TAMLA, which is adenectomy, video-assisted mediastinal lymphadenectomy, and trans-cervical extended mediastinal lymphadenectomy.
Okay.
And so surgically
And what
you have
else?
VATS, so VATS
Yeah.
and thoracotomy biopsy.
That's right. So don't forget open surgery. Okay. So last is thoracotomy and open surgery, because you
Yes,
could do a thoracotomy, stage the mediastinum, and then do a lobectomy. So don't
Yes.
forget open thoracotomy. Nowadays, everybody forgets to say open thoracotomy. Okay.
Sure.
Now, my next question to you is, again, these are all specific questions with specific answers. Okay. Everybody understand? And again, for part 2, we will definitely ask you this. For part 1, there will definitely be some question in the MCQ for sure. If not one, there may be 2 or 3 questions in the MCQ. So I'm giving you very specific answers. So EBUS. Okay, now my question is EBUS. Okay, Nikhil, come in. EBUS. What lymph nodes will you stage with EBUS? Actually, just wait. Before that, let me just tell me. My question to you, Nikhil, is if you didn't have EBUS and all that, or if you had EBUS, why would you do mediastinoscopy in a patient? What 3 situations would you do mediastinoscopy in a patient? Very clearly demonstrate to me 3 answers.
Sir, lesion in the lung with image detected lymphadenopathy.
What size?
More than 1 centimeter.
Okay. Second thing. Second characteristics which will ask you to do a mediastinoscopy. Do you biopsy all lymph nodes more than 1 centimeter? So what is the second characteristics you're seeing in front of you? I just showed you this investigation.
PET scan.
Yeah, so a PET positive mediastinum.
Multiple PET uptakes.
Not multiple. Even if it's a single PET uptake, you still might want to do mediastinoscopy. So
Mediastinoscopy.
first characteristic is a CT showing an enlarged lymph node greater than 1 centimeter. The second characteristic is an FDG positive PET. And the third characteristic, when you want to do mediastinoscopy, even if you don't have a lymph node seen, either EBUS, EUS, or mediastinoscopy. What is the third? Central tumor. Thank you very much.
More than 3 centimeter peripheral.
And more than 3 centimeter.
So T2, more than 3 centimeter or larger lesions. Pathologically enlarged lymph nodes more than 1 centimeter in the short axis diameter. It's important to say short axis diameter. Increased FDG avidity on PET and centrally located tumors. This is the answer I want from you in the exam. When will you consider staging the mediastinum? Either by mediastinoscopy or EBUS or EUS, it doesn't matter. But you have to tell me these 4 points, okay? So now my question comes to you guys, okay? Soumya, you come in now. Enter. Is Danesh also with us?
Yes, sir.
Okay, Danesh, you come in and tell me what is the Naruke's classification of mediastinal lymph nodes? Or you can tell me the WHO classification. I don't mind which one. Just tell me some sort of staging of lymph nodes.
So the lymph node stations, one of the cervical lymph node stations, mediastinal lymph nodes, and hilar lymph nodes. And the one classification is divides WHO classification is divide lymph nodes into 1 to 14.
Okay, 1 to 14. So tell me what is 1. What is 1? What is 1? Don't
one
read
are the cervical lymph nodes, and then
so wait 1 minute. Go slowly. This is very important because I will ask. The whole examination is about this staging. Okay, you must know the stations clearly. Okay, 1 is what? Highest cervical.
Highest cervical.
Yeah? Or highest mediastinal. Sorry, not highest cervical. Yes. Lowest cervical, highest mediastinal. Okay. Okay, so let's go through this in more
and
detail. Wait, I'll go through this in more detail. Okay, so now go through this. One is what?
then one also includes the supraclavicular and the sternal lymph nodes.
Yeah,
And
any
two
of these are one, correct. So
Yes, sir.
now tell me what is 2.
Two are the paratracheal lymph nodes divided into the 2R and 2L.
Very
And,
good. What is 3?
Prevascular and retrotracheal.
Prevascular and
Somebody else come in. What is 3? Quickly.
Prevascular and retrotracheal node.
So what are they called as? 3 what?
3A is prevascular and 3P is retrotracheal.
So A is what? What
A
does
is
the
prevascular and
no
P
no
is
what does the
retrotracheal.
word A stand for?
Anterior.
Anterior. And what does the P stand for?
Posterior.
okay,
See,
anterior
a
to the
simple
aorta.
question, but you kind of get muddled and you not able to reproduce. It's a simple question. 3A is anterior, which is prevascular. 3P is posterior, which is retrotracheal. Is it clear?
It's
Okay, Simran, come in. What is 4?
So 4 is lower paratracheal divided into right and left.
Okay, good.
So 5
What
is
no? What is 7?
so 7 is subcarinal.
So,
Okay. What is 8R?
So 8R is right paraesophageal.
Okay. What is 8L?
So left paraesophageal.
Okay. Soumya, come in. What is 9?
Pulmonary ligament nodes.
Inferior pulmonary ligament. Well, not. See, there is a superior pulmonary ligament as well, though, textbooks don't describe it. So you must specifically say 9 is inferior pulmonary ligament. Okay, good. What is 10?
hilar.
Hilar nodes.
Okay, Nikhil, what is 11?
Interlobar. Lobar.
Interlobar.
Interlobar. हाँ.
What is 12, 13, and 14?
12 is lobar, 13 is intersegmental, and 14 is segmental. Sorry,
subsegmental.
Segmental and subsegmental.
segmental and subsegmental.
Okay. Who else is there? Biswarup, what is 5 and 6?
5 is subaortic and 6 is paraortic, sir.
Good. Okay. So now I want somebody to go through from 1 to 14 in one go. Okay. Nikhil, 1 to 14 in one go.
Sir, one right or left supraaortic, supraclavicular node or a scaling group. 2 are right upper paratracheal. 4 are right lower paratracheal. 3A pretracheal. 3P retrotracheal. 5 subaortic. 6 paraortic. 7 subcarinal. 8 paraesophageal. 9 inferior pulmonary ligament. 10 hilar. 11 lobar. 12 interlobar.
11 is interlobar.
11 is interlobar.
12
lobar. 13 segmental. 14 subsegmental.
Okay. So look at these pictures. Okay. 3A and 3P. Can you see that? Hello, everybody clear? 3A and 3P. So the one on top
Yes.
of the SVC is 3A and the one behind the trachea is 3P. Okay. All right. And this is 5 and 6. 5 is subaortic and 6 is aortic. Okay. So now we will start the discussion. Give me an answer. Nikhil, you stay there and give me an answer. Which nodes can you access with EBUS?
Sir, 2R, 2L, 4R, 4L.
What about 1? What about 1?
One by we can directly
But what is accessible by EBUS? So is 1 accessible or not?
Yes.
Yes.
Yes,
Yes, it is,
it
sir.
could be accessible.
yes,
Good.
it could be accepted.
Yeah. Okay. Now 2.
2, 4, and 7.
2, 4, 7.
7.
Okay.
And
Simran, sorry, are you still answering? Finish your
yes,
answer.
and in extended mediastinoscopy.
No. So,
No.
my question is, what is accessible by EBUS?
EBUS. Oh,
So,
yes.
have you finished your answer?
Yes.
So 3P.
Simran, 1 minute. Simran,
So,
what is accessible by
so
EBUS?
EBUS level 1 can be accessed 2 RNL, 4 RNL. So 3P can also be accessed, and 10 RL, maybe even 11 RL, sir.
Yeah. Okay. So you forgot
7.
7 actually in the
7,
top.
yes, and 7 also.
Okay. What you miss, Nikhil, is 10. Okay, 10 and maybe 11. If you want to get 13 and 14, what can you do?
EMN, sir.
Good. You do EMN. Okay. It is possible to go peripheral with the EMN probe. Okay. Next question. Soumya, come in. Soumya, what is accessible by EUS? Actually, 1 minute. Stop. I want to come back to the previous question. Simran, stay with me.
So,
you gave me all the numbers. My question to you is, what about 5 and 6?
so
EBUS.
5.
EBUS.
So
Okay,
5.
5 and 6.
Yes, so 5 and 6 can be accessed by EBUS, sir, but it is only done in centers, very few centers, with because it's a highly expertise-oriented procedure, so it can be done by EBUS, sir.
Okay. 6. 5, I'm okay. 6, tell me, is there any papers which are talking about 6 by EBUS? How do they do it?
So it is done. It is done from the trachea only, but going between the left common carotid and the innominate artery.
No. EBUS. We're talking about EBUS. Can you access 6 by EBUS?
Yes, I mean, you can, but
there's the aorta sitting there.
So you approach it superiorly, sir. Going superior to puncturing the trachea much superior than where the lymph node lies, and tracking it down to the lymph node.
Okay. So if in an exam you're asked this question, okay, you speak about everything else in terms of 5 and 6. I like what Simran said. It should be done only in a highly specialized center who have a backup of a surgeon.
Yes, sir.
Okay. There is literature which is talking about 5 by EBUS and even 6 by EBUS, and they're talking about a trans-aortic biopsy. Okay. So there are specialized centers which talk about trans-aortic biopsy. In the exam, you should never say these things. Okay. But I'm just giving you the literature that is published. Okay. All right. Soumya, come in. EUS.
So 1, 3P, 7, 8, 10.
7, 8, 10. Okay. What else can you get with EUS in a lung cancer? 9 also, Soumya. You forgot 9. But what else can you get? Okay. Nikhil, come in. What else can you get with EUS specifically? I agree with everything that Soumya has said, except she didn't mention 9. But what else can you get with the EUS? Come on, guys, quickly.
The tumor itself?
The tumor is
So
okay.
may I take this question, sir?
Okay, Simran, you come in. Tell me what else can
Sir,
you get?
liver, adrenal, and celiac axis nodes.
Excellent. Intra-abdominal pathology can be accessed with an EUS scope. Okay. You can even do a transgastric biopsy, or you can do a transduodenal biopsy, or you can get into the liver. Okay. So very good. Well done. And adrenal can be got specifically using a long EUS scope. Okay. So well done, Simran. I like that answer. And of course, don't forget 5, and sometimes 5 may be accessible by EUS. 6 is usually a little difficult, but 5 may be accessible by US, particularly if it lies a little posterior. Okay, the subaortic lying posterior can be accessed by US. Okay, Biswaroop, are you with us?
Yes, sir.
Okay, mediastinoscopy. What can you access? Is it making sense, guys? Are these questions
Yes,
making
yes.
sense or no?
Perfect,
Yes,
sir.
sir.
Perfect.
Yes, sir.
Yeah, are you learning something or no? Good.
Yes, sir.
So come in, Biswaroop.
Yes.
Mediastinoscopy, what can you access?
So 1, 2, 4, and 7.
1, 2, 4, 7. What else?
5, 6.
Yeah, 5, 6. Okay.
But
Yes.
Possible
5.
if you go laterally.
Yes, yes.
Experienced person, 5, 6 possible. But what else you forgot, man? One important thing you forgot. How do you make it?
3.
How do you make sure the tumor is N1?
4.
4 is not N1. Okay, stop. Ganesh, stop.
Highland nodes.
10. Okay, so I gave you a very specific clue. So N1 is 10, not 4. 4 is N2. Okay, all right. So if you want to get 5 and 6, and you want to get a complete dissection by mediastinoscopy, how do you do that?
Sir, my voice broke in between. I couldn't get that part, sir. Please, sir.
My question is, if you want to do 5 and 6 clearance,
Yes, sir.
and you want to biopsy both sides, right and left side, doing a good complete clearance, what is the access called as?
Transcervical extended mediastinal lymphadenectomy.
Okay, so TEMLA.
Yes, sir.
So what is VAMLA and what is TEMLA?
It is with the videoscope, is videoscopic extended transcervical mediastinal.
When you use a video mediastinoscope, it's called as VAMLA. And when you go extend it into the left side and right side and go into station 5 and 6, it's called as TEMLA. Okay? All right,
Yes,
good. So next question, surgically, what can you access? By the way, just 1 minute. You said mediastinoscopy 2, 4, and 7, right? But you didn't tell me R and L. Okay, you have to say R and L. Okay.
Yes,
That's
sir.
an advantage of mediastinoscopy. You can go both sides.
Both sides.
Next question. Surgically, what can you access? VATS, what can you access?
Sir, 1, 2 RL, 3 AP, 4 RL.
No.
5,
If you are, hang on. If you've got, in this patient, can you access 4L by VATS? This patient who's got a tumor on the right side, can you access 4L by VATS?
No, 4R, ipsilateral 4.
Absolutely. My question was very specific, okay? So by VATS, you can only access the same side and anterior to the trachea, but you can't go to contralateral side, usually. You agree with that or no?
Yes, sir.
That's why mediastinoscopy and TEMLA have an advantage over VATS in terms of being able to access both sides in a lung cancer. Whereas VATS can access only one side, the side that you're operating. You will not go to the opposite side, usually. You agree?
Yes,
okay,
sir.
so get this point. I'm getting a point across to you.
Right, sir. Yes.
VATS cannot access the opposite side. Okay. All right. So next question is surgical accesses. You've already told me. Nikhil, just repeat the 3 surgical accesses that you know. Quickly. Come on, get on with it. I want to finish this slide. Nikhil, are you with me?
Yes, sir. Endoscopy, bronchoscopy, EBUS.
We did that. Surgical access. Talk surgery.
Sir, mediastinoscopy.
Good. What else?
VATS, video assisted thoracoscopy.
Hey, marega tere ko bhi main. Just come in a sequence now. Come on. Give me the
TEMLA, mediastinoscopy, video assisted mediastinoscopy, and transcervical extended mediastinoscopy.
Okay, what else? What are the other surgical accesses?
So video VATS.
Before that,
Chamberlain procedure.
Yeah, anterior mediastinotomy.
Mediastinal.
VATS and thoracotomy. Okay, this is what is the answer I expect from you. So whenever I say surgical access, you must mention VAMLA, TEMLA, anterior mediastinoscopy, VATS and thoracotomy. Okay. All right.
Yes.
Now quickly, just quickly to show you how we do it. This you know. Describe to me a cervical mediastinoscopy.
Sir, transverse cervical incision is taken above the suprasternal notch. Strap plating.
No. See, thoracic surgery, no? So anesthesia is important. Okay. Why? What is the significance of anesthesia in this as opposed to a thoracic surgery case? What is the difference in the anesthesia for a mediastinoscopy versus a lung resection? Come on.
Sir, the access,
Simran,
access to the mediastinoscopy is through the from the head end only. So that
my question is very straightforward. Okay, just wait, Nikhil. Simran,
So
what is the
for
difference
lung,
in anesthesia for mediastinoscopy versus right lower lobectomy?
so for lobectomy, you'll require lung isolation techniques, and for mediastinoscopy, you'll require single lumen ETT.
Absolutely correct. So you'll put in a
And so
single
you
lumen tube. You
also,
don't need a double
you'll have
lumen
to,
tube.
sorry.
Okay, so you don't need
Also,
a
you
double
have to
lumen tube.
assess for yes, neck
That's-
extension specifically in these patients. Sir.
That's fine. Okay, good. So now who is there? I can't see who's there. Nikhil, come back in and tell me the steps of a mediastinoscopy.
Sir, transverse cervical incision 1 centimeter above suprasternal notch, retraction of the strap muscles laterally, palpation, palpate the trachea and incise the pretracheal fascia, lift it up, pass a finger gently above the between the pretracheal fascia and the trachea till you and gently dissect till the till the pulsation can be felt.
No, you should not feel the pulsations. Okay, you need to go up to the subcarinal space. Okay,
Subcarinal.
so that's how you do it. Okay, all right. Now my question to you is, how do you make sure you're in the midline? What are the two features which will tell you that you're in the midline?
So there is no fat plane posteriorly.
I don't know what you mean by that.
So the tracheal margin, if you go laterally, there is a fat plane.
Oh, okay, I understood now. All right. What else? What are the features? How do you know? One, I agree with you. Okay, if it's a very fat guy, you'll get trachea in the midline. You'll get fat in the midline, isn't it? So how do you know you're in the midline while doing a mediastinoscopy?
No vascular structure.
No vascular structure, so no bleeding. Okay, that's the first thing. So there is never any bleeding if you're in the midline. But if you are bleeding from your mediastinoscopy incision, it is always a suggestion that you have gone laterally. The second way to know you're in the midline. When I talk bleeding, I mean oozing also. There is no oozing in the midline. Okay. Second thing, how do you know you're in the midline? What is that finger doing there, yaar? Come on. How do you know you're in the midline?
Sir,
Pretracheal fascia.
No, you palpate the trachea.
Palpate the trachea.
Yeah, you palpate the trachea. These are the two ways to know you're in the midline. Number one, you will not get bleeding because there is no vascular structure in the midline. And number two is you palpate the trachea and the tracheal rings. Okay, if you feel pulsations, you're not in the correct place. All right. Okay, so this is how you do mediastinoscopy. This is how you make the incision. This is, what is this? This is cervical mediastinoscopy. Okay, what is this? What is this? Come on, quickly, guys.
Mediascopy.
Yeah, VAMLA. Okay.
VAMLA.
Yeah, so this is VAMLA and this is cervical mediastinum. Can you see the difference between the two? He is looking into the mediastinoscope. Okay. And here you're looking up at the screen. That is the difference between the two. I'm showing this because a lot of you are cardiac guys and you may never have seen a mediastinoscopy. That's why I'm showing you the pictures. So this is, you're looking down the scope directly and there is a camera there. And the other thing that you have to look at is this. Can you see this handle? Can you see this handle?
Yes,
Guys,
sir.
yes or no?
Yes, sir.
The handle is holding the camera. So what is happening is she's using two hands to do the operation. Can you see that? So you
Yes,
put
sir.
in the camera and you hold it with the handle. Okay, there's a holder available. So that gives you two. So what is the difference in the equipment that you use for a cervical mediastinoscopy and a VAMLA and a TEMLA? There are three separate operations. So in a cervical mediastinoscopy, if you look at the equipment and if you look at VAMLA equipment, what is the difference? Come on, quickly. This is easy stuff.
It's a self.
Huh? Come on, guys. Who is answering?
Cervical
Simran.
mediastinoscope is a short mediastinoscope, and in VAMLA it is a camera that is used, sir.
Okay, so in a cervical mediastinoscopy, it's just a tube, and with the light going in through the fiber. There's a small fiber which takes it.
Yes.
In a video mediastinoscopy, there is a camera attached to the video mediastinoscope. But more importantly, between VAMLA and TEMLA, what is the difference between the mediastinoscope?
Sir, in TAMLA, the scope is expanding video.
Absolutely right. So a VAMLA may be done just with a single closed tube, but a TEMLA, you need to open up the two. So it is two pieces. I'll show you in a minute. There's two pieces, an anterior piece and a posterior piece in a semicircular way. So it goes in and then it opens up. So you can see it's like this, okay? It's a video scope which you put in closed and then you open it up. And when you open it up, you get access to the right and the left side, okay? So this is how you do. So this is VAMLA. Let me show you. So you're looking at the trachea, you're looking at 2, 1, 3, okay? All this, you can see everything very clearly, okay? And you have to dissect deep down and get all the lymph nodes. You have to find out the various stations and you have to get it. And what is this called as? What is this picture I've just shown you?
Mediastinal board.
Mediastinal board, absolutely right. So the specimen should be sent like this, okay, in mediastinal board. What is the difference between this and sending an histopathology?
This is frozen section.
No. What's the difference between frozen section? I agree with you. I've understood what you're thinking, but you're not able to get the message across to me. What is the difference between what you're seeing in front of you and what is histopathology?
Histopathology fixed samples are sent in formalin.
Absolutely right. This
Staging.
is fresh specimen going, okay? This is fresh specimen going, whereas in histopathology, you put it in formalin. So usually in a mediastinal lymph node, if possible, you must send fresh specimen so that they can fix it and do whatever they want to do, okay? You get better results when you send fresh specimen. Okay, somebody come in.
Sir,
Yeah, who's that? Nikhil, yeah.
so this fresh specimen, is it frozen section or pathology?
Both you can do. You can do frozen section also. You can do pathology as well on this, okay? But fresh specimen, they will fix it. It's better. So they don't damage. Too much formalin doesn't go in. So always you send a fresh specimen for lymph nodes, okay? So they have the option, if they want to do frozen section, they can do frozen section, or they can do pathology on it as well, okay? Directly stain. Okay, next come in. Who is next? I can't see who is next, but 1 minute, okay? Who else is here with me? Some new person I want to talk. I can't see who is there. Kamran, Dr. Kamran. You want to take the question?
Yes, sir.
Okay, tell me, how do you do Chamberlain's procedure?
So the internet towards me, it's, I think. I'm not
Speak loudly,
very-
please. I can't hear. Come into the microphone and speak.
My internet connection is really poor.
Okay.
I can't hear anything. Sorry, sir.
Simran, come in. Tell me, how do you do an anterior mediastinoscopy?
So anterior mediastinoscopy or Chamberlain procedure is done through the second or the third rib. The costal cartilage is excised, Sometimes you may need to ligate the internal mammary artery, or it can be done without ligating the internal mammary artery, sir. And you put in a you can put in a mediastinoscope and see the area and dissect it, or you can dissect it and take out the lymph nodes with the scope itself.
Okay, good. So it's in front of you. This picture is self-explanatory. Okay, this is exactly how you do it. The one important thing is you must put in a finger to dissect, to make sure that the vessel is not there. Okay, before you push in your mediastinoscope, after you made an incision in the second intercostal space, you put in a finger and make some blunt dissection. Okay, and always feel for the pulsations, because the aorta is there and the pulmonary artery is there. Okay, all right. Can you do this on the right side?
So there's no indication to do it on the right side. There are no nodes which can be accessed by this procedure there, sir.
No, there's every indication. Sometimes you might have a tumor on the right side, paratracheal region, with tuberculosis or mediastinal fibrosis or radiation. And in that situation, you can directly biopsy the tumor by doing a right-sided Chamberlain. So don't say that there is no indication. You can go either side, because
sir, what if it is a right heart?
Sorry?
What if it is a right heart, sir?
Come again. I didn't understand the question. Sorry.
Dextrocardia.
Yeah,
if it is dextrocardia, yeah, so you can do it. So what I'm saying is that you can do it right and left side. It doesn't matter. So there are many indications. Sometimes the mediastinum may be fibrosed. He might have TB and things, and there's a tumor in the right paratracheal area. You can actually do a Chamberlain. So you can go both sides. And then he said right dextrocardia. Very rare, but yes, it is possible. Okay. All right. Somebody, now I just told you what is the difference. This is the video mediastinoscope of a TEMLA. Can you see that? Guys, can you see?
Yes.
Yeah, so this is the difference between the video mediastinoscope of a VAMLA versus TEMLA. This gives you added space. Okay, so this is two pieces, an anterior piece and a posterior piece, and here you have the ability to, when you turn this knob, this will open up. So you go in with a closed thing, and then you gradually, gently start opening. Be very careful, you might tear a vessel. So you have to gently open it up. So this is the difference. This is the eyepiece. Okay, so the camera attaches here. This turns and opens up the video mediastinoscope. Okay, and then you have a suction and you have light source and things like that. Does it make sense? Okay, so quickly showing you a few slides on how TEMLA looks. Okay, so there you are. That is TEMLA. 1 minute, it's not moving. So a large incision, much larger than a standard cervical mediastinoscopy. You dissect it all out, get a full flap up a little bit, and then get into that area. And then you dissect out all these various tissues. You can see everything under vision. And the advantage of TEMLA is that you can do bilateral lymphadenectomy. And in fact, you can do a systematic mediastinal nodal dissection before surgery. So before you go on to the right side, if it's a right lower lobe tumor, you can actually do a TEMLA and completely clear the mediastinum. Okay, there is no evidence to suggest that TEMLA improves the the lifespan in cancer, but TEMLA gives you better staging, no doubt about it. Okay, so you dissect it all. Can you see the subcarinal space? See here, this is carina, right and left side, and that is subcarinal space. So you can get in there and do bilateral things. What is the other added advantage of TEMLA? Simran, come in. What is the other added advantage of TEMLA?
So it is higher accuracy.
Oh, we understood that. Higher accuracy, higher staging, everything. What is the other added advantage of TEMLA?
Sorry, sir, I wouldn't know that, sir.
That's okay. Nikhil, do you know what is the other added advantage of TEMLA?
Extended mediastinoscopy can be possible.
We've said that. What is the other added? In addition to TEMLA, what else can you do? If the frozen section has come back
there is a
negative, what can you do?
Lymphadenectomy can be possible.
Yeah, we said that. But if the frozen section came back negative, what can you do through the same incision? Frozen section came back
So you can do a lobectomy through the same incision.
Absolutely correct. You can do a lobectomy. You can do a cervical wax
Yes.
lobectomy through the same incision. All you have to do is come to the right, open the pleura, and you're in the pleural space. Okay.
Yes, sir.
Technically,
Yes, sir.
much more challenging. You need to be very experienced. But TEMLA has the advantage that you can continue on with the surgery in the same sitting. And if the frozen section is negative, you can do a cervical lobectomy, cervical wax lobectomy. Okay.
Sir, can lower lobectomy is possible from the same?
More difficult, technically very difficult. Technically very difficult. Usually upper or middle lobectomy is easier to do. Okay. So usually if it's a lower lobectomy, they try not to do through TEMLA. But Marcin Zielinski is the expert in this, and he has even done lower lobectomies as well. Okay. So what is the advantage of TEMLA over wax?
Both sides can be accessed.
So number one is both sides can be accessed. Well done. So good mediastinal staging. Second question, what is the advantage of TEMLA cervical lobectomy over thoracic wax lobectomy?
Sir, positioning through the same position.
It's in the same positioning, yeah. But
Same
more
position.
importantly, clinically, what is the advantage?
There is we can avoid doing there will be less pain because you're not putting in ports, you're not putting in
Absolutely. The pain is less with TEMLA. The pain is less because there is no intercostal nerves involved. Okay. With TEMLA and with subxiphoid, the pain of a lobectomy is less as compared to a transthoracic lobectomy. That is the answer. Okay. Does it make sense, guys? Hello. Everybody
Yes,
still with me or no?
Yes, sir.
Yes, sir.
Okay. 6 o'clock, 1 hour gone by. Okay. What are the endoscopic accesses? You know that we said EBUS and EUS. Okay. So let's quickly look at EBUS and EUS. What is possible? We said all of this. Okay. And the other advantage of EUS, this is EUS. Okay. So other advantage is 8, 9, and more importantly here. Okay. The adrenal glands you can get. And in fact, there is evidence that if even the right adrenal, you can go transgastric and get it. Okay. There is new technology available. So this is the advantage. This is EBUS. EUS gives you added view. Is this picture clear now? Everybody, hello?
Yes, sir.
Soumya,
Yes,
clear?
sir.
yes.
Yeah, so very important, all right? So this is the added advantage. Again, see, you can get 10, 11, 12, but usually 10 is the limit of EBUS, maybe 11, but beyond that, you should look for EMN, okay? All right, fine. Does that make sense? Good. So these are the ones you can get with EBUS. Sorry about that. Okay, so now we come to the guidelines, okay? In this patient, we'll talk about how we do, why we do. So my question is, why do we do mediastinoscopy? How do you stage the mediastinum? Anytime you answer this in the exam, I want you to use these two papers. According to the revised ESTS guidelines, okay? You must say that, according to ESTS guidelines or EACS, okay? So this, ESTS and ERS, okay? These are the two guidelines. ESTS and ERS. Does that make sense? Hello?
Yes, sir.
Okay. So now tell me, what is the advantage of mediastinoscopy according to the guidelines? Come on, quickly. This is easy. Yeah, Nikhil, come. You are the first one.
Sir,
Advantage of mediastinoscopy over EUS and EBUS. Simple question, yeah, not difficult. Come on, Nikhil. Okay, next one. Who's next? Simran, come in. What is the advantage of mediastinoscopy over EBUS or EUS?
So you get higher number of lymph node.
Excellent. Higher number of
You get-
lymph nodes. Very good.
Yes, sir. Then you have better accuracy.
So higher number of stations as well.
Higher number
Okay.
of stations also. Yes, sir.
And more importantly, you get the whole lymph node.
Yes, sir.
Okay, you get the whole lymph node.
Whole lymph. Yes, sir.
With EBUS and EUS, you only get a needle tip biopsy. Whereas with mediastinoscopy, you get the whole lymph node. Hence, the accuracy is higher. Does that make sense?
Yes, sir. And better negative predictive value, sir.
Absolutely, because you're getting the whole lymph node, and because you're getting more stations, and because you're getting more number of lymph nodes at each station. If mediastinoscopy is negative, then it is truly negative. Do you understand this? Very important, these 4 points. This question is frequently asked in the exam. Okay, advantage of mediastinoscopy over EBUS and EUS. Higher number of lymph nodes, higher station of lymph nodes, more accuracy because the whole lymph node is stationed, and more importantly, because if it comes back negative, it is truly negative. Next question to who is there? I can't see. Soumya, what will you do? How will you interpret a negative biopsy on an EBUS? Are you with us, Soumya? I don't know.
We'll take it as true negative. Yes.
Will you take it as
Take it as a negative?
Are you happy if the EBUS comes back negative? Will you be happy?
Yes. Yes.
Okay.
No, sir.
Anybody else wants a different answer?
No, sir. We will do.
We'll
have to do
If the EBUS comes as negative, then we need to do a VEMLA or a TEMLA. And if that is negative, then we go for surgery. If that is positive, then we go for a multimodality.
Okay. So the thought process is, if it's a PET negative mediastinum, and for a central tumor, you're doing an EBUS. If that comes negative, that's okay. But in all other cases, if it is PET positive and you do an EBUS and it comes back negative, then you have to do mediastinoscopy. Did that make sense what I just said? It's very important.
Can you please repeat that, sir?
Okay. If it's a PET negative mediastinum in a central tumor, because one of the indications for EBUS for staging a mediastinum is central tumors. So even if they are PET negative in a central tumor, they usually say you should stage the mediastinum. Okay. So if it's a PET negative tumor in a central tumor, PET negative mediastinum in a central tumor, if EBUS comes negative, you may take it as negative, but the best thing is to offer mediastinoscopy. In a PET positive mediastinum, if EBUS comes negative, you must offer mediastinoscopy. So in the exam, if you're ever asked, are you happy with EBUS? You should say, no, sir, I want to do mediastinoscopy. Okay. The answer should be, I would prefer to do mediastinoscopy. Is that okay?
Yes.
Everybody happy with that or no?
Yes.
Yes, sir.
Okay. Who else was there? I forgot. There were more people, isn't it? Who else is there? Who is exam going? I can't see. Kamran, are you still with us or you don't want to be with us?
Yes, sir.
Danesh, are you there?
Yes,
Danesh,
sir.
come in.
Yes, sir. Yes, sir.
Okay. How do you do histopathology? No, how do you do tissue analysis for an EBUS?
Okay. By the sir, histopathology and also will the tumor markers.
No, beta. The question is very specific. How do you do histopathology or cytology for EBUS? Wait, let Danesh try. If you don't know, say I don't know. We'll quickly move to the next one.
Sir, actually, I'm not getting the question.
Okay, my question is: have you ever seen a EBUS being done?
No, sir.
Okay. Have you read about EBUS?
Yes, sir.
Okay. So when you're doing EBUS in the bronchoscopy suite, what do you do? What else is there in the bronchoscopy suite when you're doing EBUS?
Frozen section, sir.
Frozen section is in the lab.
Okay.
What happens in the bronchoscopy suite? Okay, Simran, you come in and tell me, what am I talking about?
Sir, Rose.
Rose. Thank you very much. So now, Biswarup, tell me, what is Rose?
It is called rapid on-site evaluation, but I don't know details because I've not seen.
Okay, that's all right. That's all right. It's okay. So, Danesh, if you're ever asked, How do you look at
Yes, sir.
cytology in a EBUS? You must say ROSE, R-O-S-E,
Yes, sir. Yes, sir.
rapid
That I know, sir.
on-site evaluation.
Yes, sir.
What is rapid on-site evaluation means that a pathologist is in the bronchoscopy room with a microscope, and they put in a needle. The bronchoscopist puts in a needle via the EBUS, takes a biopsy, and flushes the cells on the slide. He makes 1 or 2 slides and gives it to the pathologist. And on the spot, the pathologist will tell you whether there is enough tissue or not, or is it malignant tissue or not. He'll do a quick stain and tell you, is he happy with the sample or not? That is called as rapid on-site evaluation. He may not give you the answer to the pathology, but he'll tell you whether should you stop the procedure. If he says there is not enough tissue, you have to continue and do more punctures. Ideally, you might have to do 6 to 8 passes through the lymph nodes before you might get adequate tissue. So the sensitivity and specificity of EBUS depends on the availability of rows. Did you understand my sentence or no? Everybody
Yes,
understood
sir.
my
Yes, sir.
sentence?
Understood.
Soumya, did you understand my sentence? Yes or no? Soumya is there or not there?
Yes, sir. Yes, sir. Yes, sir.
Okay, that means that's why it's a very specific question. Rows is part of EBUS. You need to be able to assess on site whether you have actually got the cells or not. If it's negative, then you do another pass. You put in another needle and take another biopsy. So rows is very important, okay? When you're talking about EBUS. All right. So
Can
what
I
is the
ask something,
evidence?
sir? Salman.
Yeah. Who is that? You have to tell me who's talking. I can't
Salman,
see you.
Salman.
Yeah, Salman.
Can I ask a question, sir?
Yeah,
I
go
don't
ahead
know.
quickly.
I don't know if it's relevant or not. But anyway, mediastinoscopy has got a very limited vision. How will we identify that we are taking the biopsy from the tumor lymph node or from some vessel or some other structure?
Okay. So in the old days when we were doing a cervical mediastinoscopy, it was very limited vision. And we were always worried that are we taking a biopsy from the lymph node or are we taking it from the blood vessel? Because you don't want to biopsy a blood vessel. The commonest thing is pulmonary artery that you could biopsy there. Okay. So there are 2 ways to know it. Number 1 is you look at the color. If the color is black, then it's obviously a lymph node. But if sometimes the vision may not be great and you might still be worried, then you take a long needle with a syringe and you actually puncture the structure that you see in front of you and you aspirate. If you get blood, don't biopsy it. If you don't get blood, it's a lymph node. Okay. This was in the old days, we used to do this. But nowadays with video mediastinoscopy, you don't have this problem. The vision is so much better. The light is so much better and it is 10x magnified. So then you don't really have to worry. You know you're looking at a lymph node or a vessel. But again, if you are worried and you're not sure, you can still use a long thin needle and aspirate the structure. That's how you make sure that you're not biopsying a lymph node, a vessel instead of a lymph node. Okay, make sense?
Thank
I'm
you very
having
much.
the question, sir.
Yeah, thank you very much, sir.
Sir? Hello, sir.
Yeah. Who is it? You have to give your name. I can't hear.
I'm Dr. Shweta Sharma, sir.
Yeah, hi.
Sir, the cervical mediastinoscopy side of lung for preoperative assessment of lung carcinoma, it is least reliable for a tumor located in which lobe, sir? Right upper, middle, lower, or left upper or left lower?
That's not true. The lesion makes no difference. It is the presence or absence of mediastinum. You're not taking biopsy of the lymph nodes. You're taking biopsy. You're not taking biopsy of the tumor. So it doesn't matter which lobe the tumor is in. If there is a mediastinal lymph node present, the mediastinoscopy is extremely good and extremely sensitive. It is the best investigation,
MCQ question,
but it is the
sir.
most. Sorry.
So this was the MCQ question, sir.
Yeah, well, the answer, if it's an MCQ question, then it is a lower lobe because lower lobes do not metastasize to the upper tracheobronchial tree.
So left lower or right lower, sir?
It's left lower. If you have to, if you put on the spot, it is left lower. But I think this is a faulty question. It's not a correct question. because
Okay, sir.
but if you're put in the spot, it's left lower, because left lower more likely comes only to 9, 7, 8, and 9 and 10. Usually it doesn't come to higher up. So if it's an MCQ question and you're put on the spot, it is a left lower, which is the least reliable. But this is not true as a philosophy, because mediastinoscopy is not used to biopsy the tumors. It is used to biopsy lymph nodes. So the question that they are asking you is not about mediastinoscopy. They are asking you which tumor, which lobe of the tumor metastasizes to the mediastinum. That is the question that they are asking you. Okay. So
Thank you,
superior mediastinum, left lower lobe usually does not go to the superior mediastinum. If it has to go, it will go to 5 and 6. So if it's an N2 disease in a left lower lobe, it will be 5, 6, 7, maybe 4L. Okay. But usually beyond that, it cannot go. All right. Okay.
Sir,
So,
sir, I have one doubt, sir.
Yeah,
Sure.
sure.
Sir, if we are getting like three or more than 3 lymph node stations, and we are getting adequate samples with the help of an endobronchial method, then why do we do an mediastinoscopy outrightly? Because it might be that the frozen section comes out to be positive, and
hang on. The guidelines are going to come, and nowadays there is no indication to do mediastinoscopy as a first choice.
Okay, sir.
There is no indication. Always you do EBUS. That is the first 1C evidence. Okay. So if somebody says do mediastinoscopy straight away, that is not true. All the guidelines say that you have to do EBUS, not mediastinoscopy. Okay. All right. Is it making sense, guys? So far, so good? Yes or no?
Yes, sir.
Hello. Give me feedback really quickly, because we need to do a little.
Yes, sir.
So tell me VAMLA versus cervical mediastinoscopy. Couple of points. This is from the guidelines. Okay. So similar morbidity. The mortality is less than 1%, but VAMLA is better than cervical mediastinoscopy. Okay. This is straightforward. Okay. Now give me the evidence of VAMLA versus TEMLA, which is better. Quickly. This is easy. Simran, come in and quickly give me.
So you have higher number of lymph nodes on TEMLA.
Good.
You can get high number of stations of lymph nodes on TEMLA as well.
Very good.
You have better accuracy on TEMLA, and but the morbidity is more on TEMLA, because there are chances of injury to the recurrent laryngeal nerve, thoracic duct injury, and cosmesis is an issue with TEMLA because the incision is big.
Excellent. That is perfect answer. Okay. So number 1 is larger incision in a visible site. Number 2 is there is a definite incidence of recurrent laryngeal nerve palsy, 3 to 4% if you look at the literature. Look where my arrow is. So you have 3 to 4. Everywhere you can see that TEMLA has a risk of recurrent laryngeal nerve injury, and of course pneumothorax and pleural effusion. That's okay. That's not a big. While doing a TEMLA, you created a pneumothorax. What are you going to do? Come in, Biswaroop.
Sir, put a chest drain, sir.
Okay, good answer. Put a chest drain. Fine. Or you could actually put in a drain trans-cervical as well, if you want to. But most people will put in a chest drain, and that's a good answer. What is the sensitivity of EBUS, EUS? Over the literature.
90,
Both have around
90.
90% sensitivity with 100% specificity.
So good. So sensitivity is between 80 to 95%. Okay. Specificity is very good, 100%. So the answer to this specificity is that if the understanding of the specificity is that if EBUS or EUS comes positive, it is definitely positive. That is the answer. That is the understanding of this second line, specificity. If it comes positive, it's truly positive. But if it comes negative, it may not be negative. Did you understand this or no?
Yes, B is 0.
That is why sensitivity is lower, but specificity is higher. Is everybody clear about this? This is an exam question. Okay.
Sir, this means that B is 0 in a two-way table.
Sorry, what was that? I didn't know. Yeah, let's not talk statistics. Don't confuse Biswarup. Just keep to the points. Okay. Okay. What do you do? Can you restage with EBUS and EUS? Nikhil. Nikhil. Hello.
Yes, sir.
Can you restage with EBUS and EUS? After the patient has had chemoradiotherapy and you want to assess him for surgery in a downstage patient, can you do that with EBUS or EUS?
Yes, sir, we can do that.
Okay, you can do that. So specificity and sensitivity?
Sir,
goes down. The sensitivity goes down. The specificity remains the same. Okay? All right. Okay. All right. Can you restage with mediastinoscopy?
Yes, sir.
Okay.
But the
problems
planes are...
with mediastinoscopy?
Yes, sir, I didn't understand the question.
Can you restage a patient who has had previous chemoradiotherapy? When you use the word restaging, it means he's had one treatment and then you're doing a second assessment. So restaging, can you restage with mediastinoscopy?
Yes, sir. There is a difficulty.
What are the problems with restaging with mediastinoscopy?
Sir, because of desmoplasia, the planes are...
What are the problems?
Fibrosis and
planes.
loss
What
of
are you saying?
planes.
Planes
Exposure is difficult.
Exposure is difficult. So you got to be a little more experienced, okay? So when you do a restaging with mediastinoscopy, you got to be a little careful because the tissue fragility is higher and the planes are lost. The normal tissue planes are lost. So you are more risk of causing damage to the blood vessel, okay? So it's important. You can restage with after mediastinoscopy, but you got to be technically more accurate. Okay, everybody okay with me or no so far? Yes or no?
Yes, sir.
Okay, now each one, I'll give you a clinical scenario. You tell me what is the guideline, okay? So that's the clinical scenario. There is a tumor in the lung, but the mediastinum is abnormal on CT or PET. PET positive lymph node. What is your next step of management?
May I take that, sir?
Yeah, Simran, take it.
So you will do a EBUS and EUS.
What is the level of evidence or grade of recommendation?
So A.
Excellent, well done.
Very high
so
level.
now Biswarup, does that answer your question?
Yes, sir.
So this is it is straight from the guidelines. In the exam, do not talk about mediastinoscopy nowadays. You have to talk about EBUS or EUS. That is what the guideline says, and it is the highest level of recommendation. So any abnormal mediastinum should be staged with EBUS or EUS. Okay, is that clear? Level of evidence A, so cannot be more. This is randomized control studies and meta-analysis. Okay, all right. There is an option of doing EBUS TBNA or EUS FNA. These are the preferred levels. But if either of this is unavailable, then you do EBUS alone. And if it comes out negative, then you do a mediastinoscopy. Did you understand this?
Yes, sir.
Okay.
Yes, sir.
So better to do both. If one is available, do one. If you have to choose between EBUS and EUS, you choose EBUS over EUS. And if either of this comes back negative, then you do a mediastinoscopy. Does that make sense? Very, very, very important this is, okay? This is an MCQ comes here because of this level of evidence. Yeah? Okay.
Sir, can I make myself clear?
Yeah.
So if everything is negative, then we would say mediastinoscopy.
Yeah. Depends on your hospital. If you haven't got an EUS and if you've got only EBUS, that's fine. If EBUS comes negative, then you send for a mediastinoscopy. If it is, the lymph nodes are only in the mediastinum 2 and 4, then you don't have to do both. You can just do EBUS and you're happy. If there is 2, 4, 8, and 9, then it's EBUS and EUS. You understand that?
Yes, sir. But the last option is still is mediastinoscopy.
Yeah, if it's a PET positive mediastinum. So my question again, I'll come back to you, Salman. I put you on the spot. Why do you want to do mediastinoscopy? Why do you want to stage the mediastinum? Forget mediastinoscopy. Why do you want to stage the mediastinum?
Just to know the option of treatment for the tumor.
So if the mediastinal staging is positive, what won't you do in treatment?
It depends upon the stage. I have to decide regarding the stage, sir.
Yeah, but you have got three options, no? Surgery, radiotherapy, chemotherapy. If you've got N2 disease, what do you try to avoid?
Surgery, of course.
Yeah, so that is why it is important. The type of treatment changes. It's not the treatment changes, it's the type of treatment changes.
Okay.
And usually in an N2 mediastinum, you do not try to operate. There are some specific situations where you operate in an N2 mediastinum, and I'll talk about that a bit later, okay? But first, just stay to this. Guys, everything making sense? Simran, is it making sense, what I'm saying?
Wonderfully, sir.
So far, you're getting concepts clear?
Yes, sir.
Nikhil, are you okay or not? Yes, okay, next stage. Okay, Nikhil, take this question. Okay, in this patient, you have a non-small cell lung cancer, but the mediastinum was normal. And, sorry, forget the normal mediastinum, okay? There is, on a CT, the mediastinum was normal, not PET, but on a CT, the mediastinum was normal. But there is some evidence of FDG avid hilar lymph nodes. Did you understand the question? So non-small cell lung cancer, mediastinum is normal, but hilar lymph nodes have some FDG avidity. The primary tumor does not have FDG uptake. Okay? What are you going to do? Tumor size is greater than 3. What are you going to do? So PET scan is negative, CT scan is negative for mediastinum, but there's a single hilar lymph node, which was PET positive. The tumor did not take up any FDG activity, but the size is about 3 centimeters. What are you going to do?
Just mediastinoscopy.
No.
Nikhil, I'll kill you. Okay, don't upset me. I'll kill you.
First EBUS, then.
I just said in the exam, don't use the word mediastinoscopy. Okay.
Yes.
In the previous slide, I said, what is the first thing you're going to say? EBUS. Okay. EBUS or EUS, depending on wherever that is. If it is anterior in the hilum, you'll do EBUS. If it's posterior in the hilum on the right side, you'll do EUS. Okay. So please do not in the exam talk about mediastinoscopy as the first option. Never. Okay.
Yes.
One question, sir.
I am repeating this for a certain reason. Okay. I see a lot of people in the exam space say mediastinoscopy. Simran, come in with your question really quickly.
So this scenario we're talking about adenocarcinoma, na, sir? This primary tumor. So,
absolutely.
So is it possible for adenocarcinoma primary that the lymph node is also negative?
Anything possible with cancers.
So then what do you do?
Anything possible with cancers. You never know what is happening. The reason why you have to biopsy the FDG avid hilar lymph node is you could have a second malignancy coming from somewhere else, or it could be the main tumor going to there, or it could be a second lung cancer. So there is a ground glass somewhere else, and the lymph node could be squamous cell. You don't know that. That is why you have to biopsy that lymph node.
Yes, thank you, sir.
Okay. Or it could still turn out to be adenocarcinoma. You don't know. Tumors behave differently when they are in the lungs and when they are in the mediastinum. So the answer is you must do it. Okay, now next question. Soumya, come in. If EBUS comes back negative, what is the next step? Soumya, are you with me? Are you not there? Okay, somebody else come in and take it.
Sir, we will still do mediastinoscopy.
Good. So the answer is mediastinoscopy. Okay. There's a very important point I'm making here. In the exam, please talk EBUS or use the word endosonography. Okay. I've used the word endosonography. When you say endosonography, it means EBUS or EUS. Okay. All right. Okay. So this is the scenario, okay? Now, next scenario, okay? I want you to look at the, Danesh, come in.
Yes, sir.
There is a non-small cell lung cancer in the right upper lobe. PET scan shows normal mediastinum. The CT shows no enlarged mediastinum, lymph node. The primary tumor has not taken up FDG and the size is less than 3. What are you going to do? Quickly, Danesh, quickly answer. This is MCQ. I will show you a CT scan with a small lesion, 2 centimeter lesion in the right upper lobe, normal mediastinum, no uptake. What are you going to do next? Quick, quick, quick. This is important.
Straight.
Okay, Soumya, come in. What are you going to do?
So proceed with surgery of the primary tumor?
No, say therapy, because it could be small cell or it could be non-small cell. Well, here I said non-small cell, so then you operate, okay? So initiate the treatment, all right? And the treatment would be, if it's a non-small cell, it would be surgery, okay? If it's a small cell, then obviously this will be chemotherapy. Okay, next test, next scenario, okay? Who wants to take it? Come quickly. Who wants to take it? Say yes, sir. Quickly take it, man. It's okay.
Yes, sir.
Nikhil, okay. I wanted somebody else to come in, Nikhil. I want the others to take a chance.
Okay, sir. I'll just.
If anybody else wants to take this next one? Okay, Nikhil, central tumor. No mediastinal or hilar lymph nodes on CT PET. What is the next step?
EBUS.
EBUS.
Thank you. You must stage the mediastinum in a central tumor. That is the message I want to get across. So in a peripheral tumor with a negative mediastinum, it's okay to go ahead and operate. But in a central tumor, no matter what the size, you must stage the mediastinum and you must offer the patient EBUS with or without EUS. Okay? And in this situation, you don't do a mediastinoscopy. Only if the EBUS comes back negative, then you do mediastinoscopy. Okay? Everybody understood or no? Yes or no? Hello?
Yes, sir.
Okay,
So
go
in
back.
this
Yeah,
case,
come, ask the question.
So in a central tumor, even if it is PET negative, CT PET negative, you have to do a mediastinoscopy.
Absolutely right. No,
okay.
Absolutely right. You must state the mediastinum. The philosophy is you must state the mediastinum. Okay, because PET negative, there is about 18%, 15 to 18% tumors which might be PET negative, but still come back histologically positive. Do you understand that? Did you understand what I just said?
Okay, sir.
So 15 to 18% of tumors may be PET negative. And when you're a central tumor, there is more chances that the tumor will spread to the mediastinum. And if it is spread to the mediastinum, surgery is not the treatment. Chemotherapy is the treatment. Yeah, chemo or chemoradiotherapy. That is why this margin is there. So even if you have no mediastinal activity in a central tumor, you must stage the tumor. And the way to stage it is either do a EBUS TBNA with or without EUS. And if it comes back negative, then you might do mediastinoscopy. Okay? This is from the guidelines. So there is nobody can question you on this. This is actual answers from the guideline. Making sense so far or no?
Yes, sir.
Guys, I need feedback, okay? Because I don't know. It's 2 hours, whether you're understanding or you've lost me or not, I don't know. So just say a loud yes, sir, and we'll carry on.
Yes, sir. Yes, sir.
Yeah. If it's getting too much, I'm happy to stop.
No, sir, please.
Okay, next situation. Who wants to take it? Biswarup, take this.
No, sir.
Okay, restaging following neoadjuvant. What
Okay,
is
sir.
your treatment? How do you restage the mediastinum after you've taken chemoradiotherapy?
Sir, with the mediastinoscopy.
Yeah, I'll kill you, man. I'll kill you. I will personally kill you. What did I just say?
EBUS.
Sir, we
Yes,
will still
EBUS,
do
sir.
a EBUS, sir.
Yeah, for God's sake.
Still do
Please,
EBUS.
please, please do not fall into these traps. Okay? Any restaging, any first time, the preferred method nowadays with the literature is EBUS or EUS. So endosonography is still indicated. In fact, mediastinoscopy is more difficult in a restaging after neoadjuvant. We just discussed that, didn't we?
Yes,
So don't come back with that answer. It is a mistake in the exam. You will lose your MCQ, okay, if you get this wrong. I'm going through it so slowly and so carefully because you'll get 5 options and you will lose the MCQ if you get this wrong. Because the first answer is always EBUS and EUS, not. See, they will give you a clinical scenario, 20-year-old patient, a 50-year-old patient with a tumor in the right upper lobe. They'll give you all of this and the answers will be just 1, 2, 3, 4. What is the next step? And if you say mediastinoscopy, you've lost the answer for no reason. I've drilled it into you that the first choice is always EBUS or EUS. Does it make sense?
Yes.
So I've repeated myself about 7 times, but still I'm getting an answer mediastinoscopy. So that's my frustration. And you will lose the MCQ. I promise you. Just like she said, you know, right lower lobe, which is it's very tricky, these things are. So you must know the guidelines very clearly. And I'm stressing so much because I want you to understand the philosophy of management. Okay. Everybody okay?
Can I ask a question, sir?
Yeah, sure, Soumya. Ask a question.
The term is restaging, as in like we have done a CT after the chemotherapy and we find something suspicious and then we are going to do EBUS. It
No,
not
what
be
happens? No. I'll tell you. What happens is the patient had a right upper lobe tumor, which was 4 centimeters, okay? Or 3 centimeters, doesn't matter. The PET was positive for station 4, station 10, and station 2 lymph nodes, okay? You did an EBUS, and the mediastinal lymph nodes came back positive. So it is N2 disease, okay? So now you have said no surgery for this guy because you know there are 2 levels involved, multi-level involved, and you send the patient off for chemotherapy. So you see the word neoadjuvant. So you gave him chemotherapy, okay? Now the patient has come back. Tumor size is 2 centimeters. Mediastinal lymph nodes are not visible on a PET scan, on the repeat staging. So will you operate on this guy?
no, we are going for restaging and we are doing EBUS.
Correct. That is the philosophy you have to understand. That you cannot operate on this guy until the mediastinum is restaged.
Okay.
Make myself clear. So you cannot offer surgery till you restage the mediastinum. Even if it is PET negative. If it was positive before neoadjuvant, you have to do EBUS. And if EBUS is negative, you have to do mediastinoscopy. Did you understand that? This is very important.
Yes, sir. Yes, sir. Yes, sir.
Yeah, everybody understood or no?
Yes, sir.
Yeah, and this is straight from the guidelines. Do not say in the exam, this is a trick question. Do not say in the exam, I will operate on this patient. Never ever say, I will operate on this patient. You have to say, I will restate the mediastinum for histological evidence of negativity in the mediastinum before I offer surgery to the patient. Yeah,
So
Salman,
just
you
one
were saying
thing.
something. Yeah.
If PET is negative for mediastinum,
Yeah.
what would we are expecting to see with mediastinoscopy?
You might still get histologically positive tumor. You want to know if tumor cells are still there or not there. So this is a clinical scenario. We face this all the time. You know, a patient has had a chemotherapy and then he comes to me, should you operate? The guidelines and the literature says that you should not operate directly. You must take the mediastinum before operating because the mediastinum may still be positive. If your mediastinoscopy comes back as positive, then you Do not offer surgery a second time. Send him for second line treatment. Do you understand that? That is the difference.
Okay.
So
Okay.
you do not operate if the mediastinum is positive. If it's negative, you go ahead and operate. But if it is positive, you should not operate. Even a second time, you should not offer surgery. You should send him off for, therapeutic chemotherapy, because neoadjuvant is always a reduced dose, reduced number of cycles, 3 or 6 cycles. Do you understand? So this guy is not operable second time around. Okay. That is why you have to do a restaging. Make sense or no, guys, or is it getting too much?
Beautiful, sir.
Okay, next.
No, sir. Good.
When you said no, I thought you said you're not understanding. Okay. So non-small cell lung cancer with an abnormal mediastinum, it is absolutely mandatory to assess the mediastinum. Now this answers your question, which you just asked me. It is, you must do at least 3 stations. You must sample at least 3 stations, and preferably the 3 stations should be 4L, 4R, and definitely 7. You have to do 7. Okay. So did you understand this guideline? It's very important. So in an exam, I will ask you, how many stations will you sample? Or in an MCQ, I'll say, I've sampled 2 stations. Are you happy with that? The answer is no. The guideline says you must sample at least 3 stations. And more importantly, station 7 must always be included in that. So you can do 5, 6, and 7. That's okay. But preferably 4R, 4L, and 7 should be sampled. Okay. You can do 5, 6, and 7. That's okay. That's not a problem. You understand that? In a left upper lobe tumor, you can look at 5, 6, and you can look at 7, but always include 7 in your sampling. Okay. That is what the guidelines say. So far so good. Everybody understood or no? There has to be absolute clarity of these thoughts. There is no confusion in these clinical scenarios, and you will face this in the MCQ or in the exam. Okay. All right. Now, next thing is, what am I asking? Central tumor. Okay. What do you do? And this is again an MCQ. I've seen this MCQ in the exam papers. If you have done central tumor, not visible at bronchoscopy. What is the next step?
EUS?
Good. You sorry, did you say EUS? No.
Yeah.
Yes.
Bronchoscopy only looks at intraluminal tumors, right? So the tumor could be extraluminal. So if the tumor is extraluminal, then what do you do?
EBUS.
EBUS. Thank you. So first thing is EBUS. If you're not getting it with EBUS, then you can do EUS. Okay. So EBUS is the first answer, and then EUS is the next answer. Okay. So this is again an MCQ. Okay. Central tumor not visible at bronchoscopy. What is the next step? EBUS or EUS. Okay. All right. All right. Left adrenal gland positive. Somebody take it. Who wants to take it? Simran, take it. You know this one. Left adrenal gland positive.
The EUS.
Okay. EUS. Very good. And what else? Anything else you know?
Lab.
The laparoscopic, but EUS specifically, what is a transgastric? Okay, it's now, it was experimental at that stage, but now it is available, so you can go transgastric. Okay, but left is more easily accessible and it's there in the guidelines, so no two ways about it, nothing to worry about it. Okay.
Yes.
Now my next question is training and things. One thing, there is an MCQ on training for EBUS. So if you're going to do endosonography, you should ideally be trained in both. Okay, simulation and supervised practical training, and there is competency assessment. Okay, forget this. This is all right. Okay, so now can you go through this guidelines? Let's go through this guidelines. Everybody can see it, yes or no?
Yes, sir.
This guideline is very important. This table, you must read it by heart. Okay, so let's look here. CT and PET or PET CT. Okay, if the mediastinal lymph nodes are negative and it is a peripheral tumor, outer third of the lung, and the tumor size is less than 3, you go ahead and operate. Is this clear? Hello?
Yes, sir.
Yes,
Yeah,
sir.
say yes quickly. If the mediastinal lymph nodes are negative, but there is N1, or if there's a central tumor, or if the tumor is more than 3 centimeters, then you need a tissue confirmation. And in that answer, you must say EBUS or EUS. And if it is negative, then you do a VAMLA. If the mediastinal lymph nodes in both these situations are negative, particularly after mediastinoscopy, then you go ahead and operate on the patient. Okay? The next situation is if mediastinal lymph nodes are positive on a PET CT or a CT and a PET, then you do need a tissue confirmation. You do need EBUS. You must do EBUS in these patients. If mediastinal lymph nodes are positive on an EUS or an EBUS, then surgery is not the answer. You have to push him into multimodality treatment. Okay? Which could be chemotherapy, could be radiotherapy, discuss in the MDT. Coming here, if the mediastinal lymph nodes are negative on EBUS or EUS, you should not subject the patient to treatment. You have to subject the patient to VAMLA or a mediastinoscopy. Okay? On a mediastinoscopy, if it comes positive, you send him for multimodality treatment. If it comes negative, then you offer him surgery. Okay? And after multimodality treatment, if you have to restage the patient, then you again offer EBUS first, then you offer EUS, and on EBUS and EUS, if it is negative, you can offer surgery if the tumor is downstage. If it is positive, you go back to multimodality treatment. Is this clear now? The mediastinum should be absolutely clear.
Yes.
Yes, sir.
This is a very, very, very important topic. Okay? Very important topic, and you must know this inside out. Please listen to my lecture again if you want to, or go to. You can when you read the guidelines.
So just one,
Very confusing. Yeah, somebody is saying something.
one last thing, sir.
Yeah, yeah. Who's
Yeah,
that?
Salman here, sir.
Yeah.
Salman, you said in restaging, if EUS and EBUS is negative, you have to do mediastinoscopy.
Mediastinoscopy.
Is that okay?
Mediastinoscopy. Yeah, yeah, yeah. You have to do mediastinoscopy
And
and then
you
consider surgery.
surgery or multimodality,
Yeah, yeah.
whatever. the
EBUS
result
and EUS negative has no validity in management of lung cancer. Anytime an EBUS and EUS
then
comes negative, you have to subject to surgical biopsy according to guidelines. Okay.
Yeah.
Now, I had a very important topic beyond this to cover, which was locally advanced lung cancer. But unfortunately, I don't have time now. So we will have to do it as a next case. Treatment and management of locally advanced lung cancer. I'll present a case to you, and then we will discuss the whole management. There are very important guidelines in this as well. Okay. All right. Thank you very much, guys. I hope it was worth it.
Thank you so much,
Sir?
Yeah,